All right, so Omar is our excellent educator today. So we're going to do a bit of a workshop today on MV and KV image matching for RTT and for IMRT and VMAT treatments. As always, if you've got any questions, please pop them in the chat, and I'll either answer them either chat or we'll stop and have questions throughout the session as well. So thank you, Omar, for getting up so early to do this for us. And it's all yours.
Okay, good morning, everybody. Welcome to the image matching workshop, KV-MV session 10. Again, my name is Omar, Kaiser Permanente, Oakland, California. There's a couple of things I would like to draw your attention to before we begin. Down here on the screen in the corner, there's a number for the slide. So it's right here. If you guys have the resource, the sheet, the print along to go along, those numbers down in the corner will correspond. So just follow that. Also, I'll be monitoring or trying my best to monitor the chat. So if you guys have any questions, comments, please leave them in the chat. I'll do my best to address those, and Claire will try to keep me honest and bring those to my attention as we present as well.
Yeah, I got those. No worries.
Appreciate it. Thank you so much. So there's a lot to discuss. Let's jump straight to the objectives and get started. So once the session is complete, the hope is that we will have some basic idea of how to best approach imaging. Feel equipped with some conceptual tools to perform matches quickly and efficiently. Read situations where repositioning and troubleshooting are needed. And finally, look at some common mistakes and go from there. So much of the material will be repeated, but it's by design. So I apologize if things seem a little repetitive or redundant, but I hope it'll be helpful for everyone. So now that we have an idea of the end goal, let's start with some information that will lead us into this session. The first thing I would like to go over and start discussing is called the pre-imaging chain. This is a group of basic checks that will help avoid problems and improve quality of our matching. So we'll first start by discussing and reviewing the prescription, verifying the scheduled imaging, quality assurance, and planning ahead. Now, of course, this is just a general guide, and as you continue to work and gain experience, you will build off of this and sort of custom tailor it to yourself, your own technique. So let's start with the prescription. The prescription is our instruction manual to the treatment. It communicates the treatment site, the basic instructions such as treatment technique and dose. It also gives us special instructions which relate to imaging, patient prep, and more. All of these can affect how we move forward with our films. So before imaging, always review the prescription. Very important. Before starting a patient's treatment course, review the scheduled imaging and setup fields entered by dosimetry. It's a good place to look for errors, review the shifts in the prescribed imaging to identify possible collisions. Large left to right shifts that you find require extra caution, and think about maybe offsetting the patient to the side of the table. This can reduce how far the couch needs to move. Save yourself time by confirming that the imaging is set up properly. Collisions are most likely to occur with the side of the MV panels because they rest closer to the table than the source. Collisions can sneak up on us when moving the gantry panels while they're out, so always be paying attention when doing that. The imaging panel distance can be adjusted as needed. Apologize, give me one moment here. Sorry about that. The generator is fixed and can't move. Avoid collisions. Be aware of the table position and where the machine is going. Move the panel to avoid collision. And again, offsetting the patient can be helpful in these situations where shifts could be large. Be careful when offsetting patients as the collision risk can move from the table to the patient. And be aware of the table. Use different angles to your advantage. For people out there using true beams, you have the ability to do on-demand imaging. So this is a great tool to use whenever you yourself feel like you're not getting enough information or we're at risk of collision. Just add an on-demand film and use your best judgment as far as the angle is concerned. So let's talk about quality assurance now. It's a necessary and vital part of the treatment process. Think of this as a filter to catch possible mistakes coming down from the doctors, the physics team, dosimetrists, nurses, and more, all the way to the table and the patient. So check anything that's missing, such as setup fields, DRRs, and mislabeled fields, mistakes in the prescription, and more. Finding and dealing with these mistakes before the patient is on the table will save both you and the patient much time and headache. The final link in the chain is planning ahead and adapting. It's important to always be thinking as we're working with patients. So think about what we're treating, where the machine's going to go, where the table will move after the shifts. Think about the imaging that will take place and what you'll need to see to perform the match. There will be times when you need to adapt to different situations. You may need to add on-demand imaging or offset the patient again. You may need to take images at unplanned angles to avoid collisions or orthotics. Some of our patients have hip implants or things that can make it difficult to see. So it's always a good idea to take a look and observe those things. All right, so that's just sort of an introduction before we start and move forward from there. So this is our outline. Today, we're going to discuss some fundamentals of imaging for abdomen, thorax, head and neck, and extremity. Much of these principles will be repeated throughout the discussion. So feel free to ask questions as we move through these topics. Many of these principles are basic by design. If you would like more complexity, just let me know and I'll happily go into more detail with you on that. So I want to add that it can be intimidating doing some things that are new. That's okay. Only practice and experience will make us better. And confidence is good, but we need to earn it, right? So this will be something new to learn and much that we do not know. There's always be something like that, things that we don't know. So let's begin the session with abdomen. Let's sight and let's discuss some principles of matching. Okay, so before we even begin to image, there are a few things we can think about that will save us time and improve our match. One is to set your area of interest. What I mean by this is set the area that will be imaged. Block areas that don't need to be seen to spare dose and reduce exposure. So use a LARA whenever possible. A LARA is as low as reasonably achievable, but always make sure you have enough information to perform a proper match. It's a nice, healthy balance. So the damage done by an improper match will always far outweigh the benefits of sparing the dose with imaging. So always make sure you have enough information. Set the technique to acquire a proper image. What do I mean by this? Well, body parts that are smaller, such as the legs, the arms, maybe the head, they don't require as much energy. So lower the KV to get a higher quality image. If you ever take an image that appears burnt out or maybe we can't see a lot, all we see is bone and that's it, it's probably because the energy is too high. Another thing to think about is what you need to see. So if we want to see soft tissue, that's better visualized with softer techniques as well. So think about the body size, clearance, field size. All of these can affect how we image. So for long, large fields, you want to move the imager closer to the patient. And when you bring that closer to the patient, this will allow you to capture more of the patient on the film, which may save you time. Maybe if the field is very big, instead of taking 2 films, you might be able to get away by just taking 1. So let's see, we're doing pretty good. I don't see any questions so far, so that's good. Does anyone do any?
Sorry, I mean, there was just a couple of questions
Oh,
that are
sure.
probably like scrolled through your screen, probably haven't seen them.
Oh, got it.
Um,
Okay.
yeah, so there was just one at the very beginning about when an image is made before treatment with MV and the result is undesirable or an error occurs, do you repeat the image again?
Yes, that's a good question. Thank you so much for asking that. So if you ever get an image that is difficult for you to visualize to perform your match, please reattempt to take the image and make adjustments if needed. So there's a few different ways we can adjust the image in order to optimize it, to better see what's going on. And so one of those things that we discuss is changing the energy. If the energy is too high, oftentimes all we'll see is the bone and a lot of the other information will be cut out. If the energy is very low, and I'm talking about KV here, by the way, sorry. If the energy is low, the KV energy is low, then sometimes it's hard to see the bone and we see a lot of soft tissue and it can become a big blur. So whenever you find yourself in a situation where you cannot see what you need to see, it's very important that you do not move forward, but instead think about troubleshooting your head, think about what we can do to fix that and brainstorm. So that's a very good question. Never be afraid to reimage. Again, um, the damage done by an improper match is always far greater than the consequence of reimaging to do a better job with your match. I hope that answers your question.
Perfect. Thanks, Omar. And there was just one other question. Can you explain about field and image matching in CSI? But you might be
Oh,
getting to
yes.
that during the presentation. So.
CSI is a complicated treatment site. There are many different techniques available for treating that. So one of the more commonly utilized techniques are gap and field techniques. And during this technique, there's a gap inherently between multiple fields, and we feather that. So over time, we move that gap up or down the patient to sort of equalize the dose across the spine. So CSI stands for craniospinal irradiation. And so when you're imaging that, our technique that we use at Kaiser is monoisocentric. And so each field shares a relationship with the subsequent field. And I apologize, they're not monoisocentric, but they do overlap. So when we do craniospinal cases, they're very long fields. They include the brain and the whole spine. And so it's important that when you are setting these patients up, that they are lined up from top to bottom. So my recommendation for that would be to start at the top. The head will be very difficult to move on a craniospinal. It's usually underneath a mask. It's indexed. And so if we find errors at the head at the end, there's very little we can do except for start over. That's very time consuming. So again, my recommendation would be to start at the head, image there, perform your match, make sure the cranium is on and everything looks good. And then once you've established the cranium, then move your way down the spine with imaging. Sometimes you can't simply just move the panel. You actually have to move the table in order to see that lower part of the spine. So, perform your shifts as they are planned and then continue imaging down the spine. And now as you find that the spine is off, I would recommend moving the patient rather than the table. If we shift the table after we've established our cranium, then what we do is we fix the spine, but then we've just created a mismatch up at the cranium. Now, this is for a technique where the fields all overlap or abut each other or share a relationship with each other. That would be my recommendation for that. For gap and feathering, there's more forgiveness here because there's gaps between each field. And so if there's small adjustments that need to be made, it's usually less of a consequence there. So again, follow your site's protocol and workflow guide. But I'd be happy to discuss that in greater detail. Again, very good question. And CSIs are can be very complicated setups. And so I'd be very happy to dive a little bit deeper into that at the end of the presentation.
Excellent. Thank you, Omar. That's all the questions we have for now. So I'll let you keep going on with your slides. Thank you.
Oh, you're welcome. All right. So again, we want to make sure that let's talk about the imaging here in this abdomen section. We want to make sure that we're using proper techniques to image. And then we talked about body parts that are smaller might require a lower energy for KV films. And let's talk a little bit about soft tissue. When you want to see soft tissue, lower energies on KV films will highlight those a little better. Some examples where you might want to see soft tissue would include maybe a leg where you're treating soft tissue and not bone, extremities, the arm, things such as that. And then we talked also about bringing the field size closer to capture more of the image. So let's go ahead and acquire our AP film, and then we'll go on from there. So this is a T and L spine case, and we've just acquired our image, and we can see some nice hardware there. And let's continue. So it's always best practice to maximize the visibility when performing any match to make things as clear as possible. And filters are a great tool. The content filter is for enhancing soft tissue and bony anatomy together. And let's see if I can, my arrow here is pointing out where you can find the filters. They're up here. And other filters can enhance imaging in meaningful ways too. So it's important to cycle through them even when you're having difficulty seeing something or like you're having an issue, just cycle through them till you find something that's able to visualize that better. Now let's briefly look at enhancement with the content filter applied. As the filter is being applied to each image, we can see that the bone and soft tissue appear easier to identify together. So we have the therapist identifying the filter now. We can see the difference that it's making. Window leveling is another great tool we can use to increase contrast, making it easier to see. Always take your time. Pressure will rise when patients are lining up, but the goal is always to provide the best and safest treatment possible. Saving time by rushing is never worth the drop in the treatment quality. So that's important, is to take our time. All right, let's move on. So I have a question for you guys. When we're matching, again, this is a TL spine. We have an AP view and a lateral view. Can anyone tell me like where you guys start? Do you guys start with the lateral? Do you start with the AP? If you start with the lateral or AP, what do you guys kind of focus on first? And I'll wait for any answers in the chat. I'll give you a few minutes. And then if we don't get any answers, then I'll just continue.
The question again, please.
Okay, so who decides if imaging is matching or not? AP, good, good. I like that answer. You could start with the AP or the lateral. We'll go over that in a moment. Those are good answers. I want to address the question by Mortada. Who decides if the imaging is matching or not? So over time, you'll develop an understanding of what your doctors at your facilities are looking for. When you're matching to specific sites, there's a couple of things that we can do to ensure that our match is on. And one of those is to enable contours. Now, contours can highlight the areas that we're treating. They can visualize and show us what we need to match to. For example, if we were treating the spine here and you saw a big red contour maybe around this area right here, we would know that this is the highlighted area that we would want to focus on the most. Now, who makes that decision? Well, on the first day that you treat a patient, on the first day you treat any patient, you need to have an approval by the doctor. So the doctor sort of let you know what is a proper match and what is an improper match. So when you perform that match on the first day and you present it to the doctor, they will give you feedback and let you know if this is a good match or not. And if it's a good match, they will approve it so that you can go ahead and treat. So that's a good question for the doctor. They typically answer that for us first. They determine whether the match is good. And then every day after that, we want to follow that blueprint, that first day, how we matched on that first day. And your doctor will give you feedback, an offline review. They may reject some films. They may put some change requests in. If anyone has any questions on what those are, we feel free to ask that in the chat. But yes, they'll like either review and approve or reject or give you change requests, and that will guide you over time on how to perform those matches. I hope that answers your question. I have some answers here. Focus on alignment of spine. Start with the AP. These are all great. Looks like a lot of people do the AP first, and that's good. So because a lot of you are doing the AP first, I'm going to discuss a strategy that's a little different. So it's all good. It's all similar, but we can start with the lateral. So it should be noted sometimes the lateral is better suited for soup to inf adjustments. And sometimes the AP or PA is better suited. So let's use the spine for an example. The lateral is usually better for soup and inf adjustments. Of course, there's always exceptions. A good match could be performed using the AP. However, the bones tend to overlap from the AP view because of the curves in the vertebral body, the column. So it takes slightly more time and care when aligning the vertebral bodies in the soup and inf direction from this view. So it's good practice to use both AP and lateral, but if we start with the lateral for this type of adjustment, soup and inf, then we might save ourselves a little bit of time because we can clearly see the top and bottom edges of each vertebral body. And a lot of people start with the AP to do the left, right first, and that's perfectly fine. That's also a good place to start. But I want to point out that for soup inf, it may be a little bit better to use the lateral because you can see the top edges of these a lot more clearer here and here than you would on, say, this, because you're actually seeing an overlap here in these spaces. Okay. So let's watch as the therapist performs the match. They're going to start with the lateral on this one and reviewing the spine using the hardware as a guide. We always want to use hardware landmarks. They're going to adjust the ant post first and then the soup inf. Then they're going to go ahead and move on to the AP view to address the left-right adjustments. Okay, so the therapist is now going to kick the couch. I don't know if you guys caught that, but there is a little bit of a crookedness going on in the spine. And so there's a couch kick that needs to be applied here. So every facility has some quality assurance performed routinely on a couch and gantry. And some of these check the accuracy of couch movements. Larger shifts are inherently associated with less accuracy. So the bigger the shift is, usually the less accurate it is. So be mindful of the tolerances that your physics teams places on your shifts. So when applying these rotational adjustments, be aware that the image will turn at the center. And so the top end of the image will swing out one way, and the bottom end of the image will swing out in the opposite direction. So it's important that after we match, that we always review the entire match altogether. So the therapist is now applying that rotation, dragging the mouse on that wheel there, and then he's going to review the entire length of it and fix that left to right. Very good. So I have a question for you guys. Let me just use painkiller and then take the port. I like that. That's funny. Do you delete the image if it's not matching offline? How would you delete this in TrueBeam? I personally, this is a question that we have in the chat. I personally do not delete any films. A lot of people delete films because they feel it makes things cleaner. But what deleting films can do is actually lead to some potential errors. Now, if you know what you're doing, it's fine. You can do this. I would check with your policy at your center. I don't delete films because I like for there to be a record of how we need to move the patient on a daily basis. At our site, we have lots of patients. And so having all the films offline can be a good indication and make a good case of why this particular patient needs more time. So sometimes we will schedule patients in larger time slots, and we can use that as valuable data to highlight to the doctor, the physicist on why and how this patient might be challenging. So for me, I don't delete, I always keep, because I think it's a good idea to have a record of that whole treatment. You can delete online or offline. Let me see with my arrow here. Over here, I believe if you're matching and you click this tab here, pardon me. If you use this tab here, you're able to pull out a menu that allows you to delete the films online as you're actively working. The risk here is that if you delete a previous film, you could be matching with an old AP and a new lateral, etc. So I would not advise that. Offline, you can also delete images. There's a menu bar up here, and it's under review, I believe. And you can go in there and delete images as well. In a situation whereby the doctor could not give good judgment in the first matching, that is when the doctor is wrong and the radiation therapist discovers this information and informs the doctor what happens. So the responsibility, this is a question in the chat, the responsibility for approving the matches falls on the doctors. We're all human. We can all make mistakes. If the doctor makes a mistake, and it's something that you discover, my advice would be to tactfully bring it up to your physics team first for review. Sometimes we look at things and we don't see what the doctor sees. And the doctor, obviously has a different perspective on things sometimes. So physics can help be that middle ground to help guide us. And instead of us going to the doctor and perhaps dealing with that uncomfortable interaction, physics may step in and do that for us. So physics is a good resource to use if you have any questions about matching. Dosimetry is a good resource to use if you have questions about the plan, and then they can bring those concerns to the doctors. But if you have a good relationship with the doctors, it's never a problem to ask for the doctor to take a second look for a second opinion, and then ask why they might have made this particular match so that we all understand better. I hope that answers your question. Doctor has to verify imaging for matches, usually on the first day and then every day after that. A lot of centers will have the doctors approve them on a regular basis, every few days or every day. Okay, so let's move on. I want to ask you guys quick questions. What are some landmarks that you guys use for matching abdomen and this area here? See if we're doing the spine or some soft tissue, say like pancreas. What do we use for landmarks? So I'm going to throw some out here. We want to use hardware and implants. They're good guides that we saw that used here. The Carina is a good one, especially if you're doing spinal cases. Carina can help you determine whether you're in the correct vertebral body or not if you're imaging higher up on the body. You can use the vertebral bodies, especially if there's something unique about one. You can use those as guides. The ribs are a good landmark. We have floating ribs. Floating ribs are, sorry, we have some messages here. Floating ribs are these ribs over here that kind of shoot off the spine and kind of just stop. This is usually an indication of where T12 is. We can use the spinous processes. So I see that on the chat. That's a good one. That can also be a guide to help us match the spaces, intervertebral body spaces. That's a good one. I'm seeing that in the chat. So those are all good answers. We can even use organs or stents. People have surgery or have anything placed in there, we can use that. And injuries and anomalies are also a good tool to use. I see vertebral body in there. That's a good one. Okay. So these are all good landmarks. The this was a good match. What I would have liked to see happen at the end. Can anyone tell me what they might have done differently? Like if this was it and they were done and they went ahead and applied this. What I would have done or what I observed is that I probably would have taken the box off and reviewed the entire match altogether. So this is something that's important for everyone to do. Always check the entire match all together whenever you're finished matching. That's important. All right, so who can tell me something about color blending? This is a tool that we can find up here somewhere in the corner. I believe it's this one right here. I don't use it very much. I'm not a huge fan of it, but it definitely is there. And I know therapists that use it quite often. They annoy me when I'm working with them. I'm just kidding. So color blending is when the DRR is displayed in blue and your acquired image is displayed in orange. They're two different colors superimposed on these images. And when they're overlaid, they combine and appear white and gray. They lose their color. So when they overlay and they lose their color, this is supposed to indicate that the colorless area is matched. This can help some people visualize the match better. Personally, I think it can make things a little more difficult, but everyone is a little bit different in how they match. I would say that the value for this tool is better suited for cone beams, CBCT, where matching soft tissue can be difficult to place. So having that color filter can help you see things that you might miss. If you do use this filter for orthogonal matches such as this, then my recommendation is to disable it once you're finished and verify the match without it before proceeding. So we have a question here. Yeah, not a good fan, me neither. Could be used for matching correct color will match. Yes. So whenever anything turns kind of black and white in that area, that's your indication that like it's matched. So for orthogs, it's difficult because we're matching to the spine and all this is kind of blurry and the DRR is black and the KV is gray and all in this area. So it's hard for the computer to know. That's why you see a lot of orange and blue here. So this is more a tool for cone beam, in my opinion. All right, let's move on
Omar,
here.
we've just got a couple of other questions that were kind of.
Oh, sure. Sorry.
We've scrolled past, but that's okay. So when using MV imaging and a patient and you needed to shift the patient and then you've shifted them, is it necessary to take another EPID image or not? So they've sort of heard some people do and some people don't, and which one would you recommend?
This is a very good question. So my understanding, and everyone's site is different. Again, follow the policy for your site. If your shifts are large, and my site determines a large shift as anything beyond 2 centimeters. So if your shift is large, we remember that we said that earlier on this presentation that larger shifts are associated with less accuracy for the couch. So if you make large shifts, it's advisable to take a new film to confirm that everything is in the proper place and that nothing is moved in between. So there's some reasons you might have a large shift as the patient actually moved maybe after you left the room. And so that means that they're moving around. So taking another film after you shift can confirm that the patient isn't moving, and then also that ISO is in the correct place. So to answer your question, I would say, yes, if your shifts are large, it's a good idea to refilm. If they're small, you're usually okay. It just means that a small shift is needed to get that perfectly on.
Thank you. That's a really great answer. And I think, I guess in my clinic, it depends on type of treatment you're doing. So for things like SBRT and SRS, obviously we do image mesh. Well, that's more cone beam, I guess, but you would do it pre and post shift if you do have those high doses that you're looking for. And just one more question, if that's okay with you. What can we do if there are any imaging artifacts?
I'm sorry, if there are any imaging
Artifacts?
Oh, artifacts, yes.
Yeah.
Good question. So when we're dealing with these orthogonal paired imagings or MV or KV, and we see artifact, it's a little bit different than cone beam. Cone beam is, you're going to see it a lot more streaking. It's going to affect the overall image a lot worse. But when you're dealing with something like this hardware here in the spine, it's usually pretty manageable. Now, if you have an image and for some reason the artifact is making it very difficult to see things, for the TrueBeam users out there, one of the things that we can do is to move the gantry to an oblique angle and film an on-demand film. Sorry, excuse me. So what that looks like is basically you pick an angle. If we're doing, let's say, a femur, and the femur is right in the middle of what we need to see, we can move the gantry up to an oblique and then kind of dodge that femur a little bit and take that film so that the artifact isn't, or that extremity or whatever it is, that orthotic isn't right there in the middle of our field. I hope that answers your question.
Perfect. Thank you, Omar.
All right.
Yeah, I'll let you get on with your slides. Thank you. You've been very patient answering all these questions early on.
No worries. I do want to answer this one. My understanding is low dose radiation has a greater chance for causing cancer. Would you recommend daily CBCT? There's a lot of different thoughts that go along with this idea. So the way that I think of it is the patient already has cancer. And so I'm not minimizing the fact that all the imaging that we're doing can have what's called that stochastic effect, where any single photon can induce a mutation that leads and triggers to a cancer, a neoplasm. So what I would say is that this patient is already suffering from the illness. And again, we're delivering therapeutic dose. So what that means is a high amount of radiation is being delivered to this patient's body. And it may range from how big that area is, but we always want to make sure that we are in the correct area and that we're treating, we're blocking healthy tissue. And so the imaging, whether it's cone beam daily or KVMV weekly, whatever it is, it's very important that those are being performed to ensure proper ISO placement. So I wouldn't be too concerned with the daily cone beam. Talk to your physics team. They will assure you that the dose from the cone beam is extremely minimal compared to the dose received therapeutically for the treatment. And also, you'd be surprised how just low it is in general. Cone beams are very, very low dose just in general. All right. Let's move forward. So now we finished our match. We can go ahead and save it. So let's go ahead and save it. And then what does saving a match allow us to do? Can I ask people this question? Anyone know what the benefits of saving the match are instead of just going straight to apply?
Saves time, so that next time you're doing that, you're just going straight to the point without having to do a whole lot of matching, I think.
Yeah, that's a good answer. That works. Yeah, that's true.
That
That's
helps
correct.
you for offline reviews to actually know whether the area you are supposed to treat, whether it was actually treated, whether the edges were properly covered.
Yes, so that's a great answer. That's actually another one I'm looking for. So saving the match will export your match to offline, and then you can review it offline. It allows the doctors to also be able to pull it up. And so if you have any questions regarding the match, it'll be right there in offline review for them. So they don't have to walk to the machine. They can actually look at it remotely. So always save the match, and then you'll be able to talk to the doctors. Just remember, it's possible to move the match after you save it. So it could be possible that the doctor is looking at one thing on offline, and yet you have a different match on the live screen. So just be careful and make sure that whatever you save and the doctor's reviewing, that you haven't made changes after, because they can approve that film and then you can treat something completely different. So just keep an eye on when you're saving it. You want to do it always at the very end. And good answers for those. Those are
another stuff again is that when you do not match the image before you save, you cannot really say this is what you treated, because it's good after matching the image before you save it. Don't just save after making the image. You have to automate the image, match the image properly before saving.
correct. This is a good point. So always match first and make sure everything is perfect and then save. Don't just save ahead of time. Good point. All right, so finally we apply the shifts. And then again, always review the entire match before moving forward and before you proceed. So always kind of look at the entire image as a whole to make sure that there's nothing out of place. Also check your shifts to make sure that you're within tolerance. So again, if you have large shifts, we talked about that earlier, you might want to refilm. Okay, so let's talk about double exposures and ports. Can anyone tell me why we take ports? So ports are necessary.
Port images are nice to be taken, especially double exposures. It will help you to actually identify the margins, especially in areas of breast treatments, whether it was properly covered and whether there's infiltration into other areas that were not properly covered. So a port image, especially of double exposure, it will actually show you different areas around that port, around that place that is being treated, whether it's properly covered or not properly covered. Because in the double imaging, you can actually view soft tissues properly and also body structures properly. So it will actually help to, and whether you have a good coverage of the area you are treating properly.
Very good. That's a good answer, Chris. I like that. There's a lot of good things that you said in there. I'm going to highlight some of those because those are very good. So a double exposure is a set of two films, and it consists of one that's closed, the port, the treatment port, and one that's open. Many organizations require an image of the treatment field with the blocks in place, especially on the first treatment as a record. So what this does is it shows us an outline of the treatment field and exactly what is being blocked. They move together when you are shifting and you're applying your match. This allows us to see more anatomy for matching purposes. So we have that closed one, and then immediately after, there's a second exposure, which is an open exposure. That open exposure allows us to see more anatomy around that blocked field so that we can do a proper match and also ensure that we're protecting the anatomy around the field. So again, they move together when we're performing our match. And some softwares like TrueBeam actually have the ability to project this shape onto an open field. And so some centers, I know here in California, we don't need to take a double exposure. We can actually just take a single open and we can see this projected on here. And our accrediting body, Astro, accepts this as proof of what we're treating. Now, again, all centers are different and accreditation bodies are different. So please follow the protocols at your center. But that's essentially why we would want to take a double exposure. It's a proof, basically.
Omar, if I can just interrupt,
what we
sorry.
actually do again is that before we do that double exposure, we cone down properly so that to reduce radiation exposure to other areas that are unnecessary. Totally cone down properly, closer to the area of interest before the exposure.
Yeah, so I would, again, follow the policies at your work. Here, what we do is we want to, for the open, so when you do a double exposure, your first image will appear closed down automatically. So all this will be blocked. The jaws will be abutting the MLC blocks here. And all you will see is just this little film here, this area. And then a second open exposure on a TrueBeam, depending on where you place your jaws and your wires, will expose the area outside. So this is all you're going to have to match. So if you cone down too much to here, you're going to end up with an image that just has the spine, this area in the middle here around this little outline. And then you're only going to get maybe a little bit outside of here. And then that's all you're going to have to do your match with. Now, on this patient, they have hardware. So we can confirm the correct body because there's a space here that's very unique. So there's 3 pins here and there's 2 pins here. Now, if this person didn't have any hardware and we did a double exposure and only had maybe this area and coned down all the way, we could make a match and potentially be on the improper body. And so when you take a double exposure, for us, what I would recommend is you don't have to have it open all the way, but make sure you're including additional information outside of the blocked field so that you can perform the match and make sure that you can look at landmarks surrounding. Always make sure you have enough information. So for some people, this may be too much. Feel free to cone down, especially on the sides. We don't need all this over here and all this over here for this case, but maybe sup and inf would be good to have. And so that's why you want to maybe make sure you have a little bit of extra information on your double exposure.
Thanks, Omar. I just want to point out, Peter has his hand raised. I didn't know.
Oh,
Peter,
hi,
if you wanted
Peter.
to ask a question.
Yeah, go ahead and unmute, Peter, and I'll be happy to listen to your question.
Okay, it's not actually a question, but a contribution to the point you just raised about the necessity of double exposure. You know, in radiography, we are so familiar with the use of anatomical landmarks. And because of how symmetrical the spines look, there is no anatomical landmarks along the spines. And that is why you need to have a double exposure so that you could be able to appreciate the whole spine and you could have anatomical landmarks that you can match perfectly. Thank you.
Oh, thank you, Peter. That's a good point. Thank you for saying that. Okay. So, so we've pretty much we've taken our exposure, we moved some things around. And so always remember to acquire your table on VSIM days, on your SIM verification days. So when you're treating that patient for the first day, it's important to acquire the table parameters. And this is important because when we treat the patient on the following days, we can have an idea if the patient is set up in a similar fashion. If the table parameters are very different, then perhaps the patient's on the table in a different way, and that can be an alarm for us to maybe check the setup and investigate a little bit more. If you forget to acquire, it's not a big deal. You can always go into treatment prep in the Varian software. I know everyone's using something that's a little bit different. I'm more familiar with Varian. You can update the couch parameters there or in plan parameters. Just make sure that all the fields match. Because if you only update one field, you're going to have an error when you vote up the patient on the following day. So you can't have different couch parameters for different fields. Also, as a tip, you can actually set the imager distance here. So if you're ever dealing with a case, say like an extremity, where the imager panel comes very close to the table because of the setup, you can actually permanently put in a farther distance for the panel, say like 60 or something like that. The standard is 50 here. You can actually make this 60 or 65 and save that so that whenever you pull that patient up and pull the imager out, it'll make it safer for that treatment. Okay. Let's observe this match for a second and think about things that the therapist does that you like. Also think about maybe some things you might do differently and just review that, and then I'll ask you guys what you think. Okay, so is there any comments? I'll be happy to go into the gating system kind of at the end. There's a lot of material to cover, but that's a good one. Say that, Ryan, and make sure that you ask me that later because that's a good one. Or if you have a specific question surrounding gating, I'll be happy to answer that. So I'm just going to talk about this match. What I would have done differently is at the end, again, look at the entire match. So just go back and forth. That's very important. Make sure everything is on. So look at the whole thing and then check landmarks to see if I'm even on the correct vertebral body. So before even matching that spine and putting that box around there, I would maybe check the pelvic crest to make sure that, or the floating ribs to make sure that I'm on the correct vertebral body. And then I would go ahead and start matching to save myself some time. Another thing I noticed, it's not a big deal here because it looks like this might be a spinal case. The image is burnt out, meaning you can't really see much except for the bone. So I might window level or apply a filter on that DRR to make sure that I can see things a little bit more clearly. So that's good of what I would have, that's what I liked in the match. So here are some takeaway notes for abdomen. I'm going to leave this up for like a minute and then we'll move forward. Okay. Any final questions about like kind of what we discussed and the abdomen before we move forward?
Omar, there were just a few questions that came up in the chat.
Oh, yes, I see some.
Yeah, so what do you call the filter where you've got the two different color fusions and when you fuse them, you get the black and the white? And where do you find that on the variant?
I don't know what the name of it is. I call it color blending. I think that's what it's called. And let me go back a few slides and I can kind of show you. It's this up here, I believe. So this is your box. This is, you use these when you're matching. This is to enable matching. This is to use like a crosshair. This is your box. And then this one over here on the side is the color blending. And this is also something you'll find in offline review. It's right up here.
Perfect. Thank you.
You're welcome.
Another question, is it necessary to take a port image for every field in an IMRT treatment?
It kind of depends on the policy of the center, and then it also depends on the way the IMRT was planned. So if you have static IMRT, also known as step and shoot, your facility may require you to take port films of every field to document, again, what was being blocked and treated.
Mm-hmm.
If you have, say, like a partial breast and they're planning it with actual IMRT, meaning that when you're treating the beam, the MLCs are moving at the same time. That's like dynamic IMRT, I believe. I could be wrong in that, but when you're treating IMRT in that way, it's most accrediting bodies don't require you to take that field. It's kind of like if you were to treat an ARC, a VMAT plan, you don't necessarily need to take ports. There's nothing to port because the MLCs are moving all the time. Versus a step and shoot where you have a main field and then you have subfields attached to that. I hope that answers that question.
Yeah, that sounds good. And then just two more questions, if that's okay.
Sure.
If someone's using, and you may not be able to answer this one, so maybe someone can answer in the chat. If you're using an Electa Versa HD, what the double exposure is called. So I think, Omar, you're familiar with the variant stuff, so maybe you don't know in the Electa system.
That's a good question. If anyone in the chat has an answer to that one, I think a double exposure just refers to a closed and open port taken together. I would assume that the terminology is the same.
Yeah.
But if anyone has anything they know differently, then please share.
And then there's now two more questions. One more. So how often would you advise that the double exposure is done on a patient?
I actually, again, think I don't find it necessary myself because, again, we're able to confirm what's being blocked on the first day without taking it. And that's through our accrediting body, which is Astro. And so as long as you can see a depiction of what is being blocked, whether you take a double exposure or not, you're okay. And you have to do that at least once, which is on the first day. Some places, if you're treating, say, a breast, you probably want to take those on a weekly basis to confirm your supraclav field, if it's a 3 field, or your actual breast beams eye view field. So you might want to take closed ports on a weekly basis for those. Every site is a little bit different, but I know that every site, at least on the first day, it must be taken. And then depending on your policy, you could maybe just take an open. And as long as that depiction of the treatment field is there, you're okay. But again, every site is different, so follow that policy.
Thank you. Yeah, it's always a good idea to refer to international protocols and guidelines when you're just setting up your systems. I think that's really good advice. And then just one more question, and then we can move on.
Sure.
Can you give us a general idea? Oh, no, not the one, the gating one. We're going to come back to that, Ryan. So out of these setup fields, which one would give the higher MU or dose?
Oh, this is a good question. This one might stump me, but my understanding is MV images, I think, result in a higher dose. The idea is if you're using, it's different for KVs. So if you use a lower dose on a KV, my understanding is that will actually amount to a higher dose. But when you're comparing KV to MV, MVs provide a lower dose. Again, don't take me on that. That's just what I think is the correct answer. If you guys talk to physics and find something different, believe what they say.
Yeah.
But I believe that
I just want to
MV...
refer back to, there was the lecture that I gave a couple of weeks ago on imaging technology, and there was a table within those slides that gave the, an estimate of the different doses for the different imaging modalities. So I just suggest people can refer back to that one for a good idea of those values. So.
Okay, very good. All right, so we discussed abdomen generally. So let's shift gears, move on to extremities. Extremities are one of the most creative areas to set up and treat because their ability to move in all sorts of different directions. These are long structures, so small movements can have big impacts. So let's talk about extremities a little bit. So now we've seen some information from earlier site. It's going to be repeated, but we're going to continue to revisit some of these and build off of them. So again, before we begin, we want to think about what we're treating. Is it the leg? Is it the arm? And ask ourselves what kind of critical or healthy structures might be in the way. And we'll get a little bit deeper into that soon. So again, set your technique. We already asked ourselves, what are we treating? This is important because the technique and filters that we use will make a big difference on what we see on the image. If we're treating bone, there usually is not a big problem imaging that. We can see that pretty clearly. But if we're treating soft tissue, we want to make sure that we can see the surface of the extremity, the skin. This is important because most extremities are elongated and they have this long shape, large amounts of muscle and fat. And in these areas, it allows the soft tissue to kind of stretch and shift around the bone. So even when the bone is matched, it's still possible for the soft tissue to be out of place. MV energies generally allow us to see soft tissue pretty well. KV imaging, on the other hand, can often overexpose the image. This is known as burning through. So basically, the image will appear to be missing the silhouette or outline of the body while showing the bone very clearly. And one thing we can do to see the soft tissue better is to lower the KV energy before we film. So if we take a film and it doesn't look good and we want to see the actual soft tissue here, which we can't, but we want to see the outline, just drag the I'll show it to you on a later slide, drag the energy over on the left side to lower the KV, and that should help. This is even more important with IMRT because with IMRT, the fields are less forgiving. They're a lot tighter. They're around the disease, the muscle, whatever it is we're treating. And we want to make sure that we're matched perfectly. Think about clearance, especially when working with extremities. Some setups require the contralateral or opposite side to be placed further from the path of the beam or be elevated. Devices can also get in the way, backlocks, things like that. So these factors can greatly increase the risk of collision. Always be thinking about that. Also, be mindful of the patient and where your imager is going. Try to position the patient to avoid collision, and move the imager further away if necessary. You can set the distance of the imager in the top left corner. And contours are great. Use them. They can help guide you and tell you exactly what we're treating, and also show us structures that are nearby that we might want to avoid. So use contours to assist whenever possible. All right. So structure contours offer many benefits when matching. They act as a reminder for surrounding anatomy and where that might be. And when images are overexposed, the body contour can highlight where the outer edge of the body should be. So contours might show where organs at risks are in relation to the field, and it's important to avoid treating unwanted areas. So review the field shape. Take this male patient, for example. Like if this were a male patient and this was the field that we were treating, what is something I might want to do before I move forward to treat the patient? Say I match this, it looks good. This is the field. What might I want to check before leaving the room or treating, beaming on? So I would say for me, I would make sure that if this was a male, that his genitals were over to the side. So because the field splits right here in the middle, I would probably go in the room and maybe just move it over or tape it to avoid treating that area if it happens to be in the way. So something like this, you could take a look at. PTVs, or target volumes, are field apertures, and field apertures are most important overlays that you'll use. So this is a field aperture or whatever that you see is in red that I put on here. That would be an example of one. This isn't actually what we're treating here on this case. We're treating the leg, but I just wanted to give that to you as an example. So this is a good idea to show us. This is a PTV, or a GTV rather. What we're treating, the PTV is maybe the margin around it, this purple. And so use those to kind of help us laser in and hone in on what we are matching on. Those must be reviewed before advancing. So we're looking at the matching here, and we can kind of see it rocking back and forth. Always make sure you have enough information to perform your match. When we perform matches without enough information, we kind of start playing a guessing game. So if I remove the top end of this and sort of went back and forth and looked at it, I'm missing a lot of critical landmarks. I can see that part of the pelvis. I can see part of the lesser trochanter there. But even if we're treating only, say, this area here, I could move forward with alignment, but this would be considered a very risky match because the leg is able to move in so many ways. I could never really be certain that my supine placement is correct. So this would be considered a negligent match or a bad match. You should never do this. The rotation of the leg can change the appearance of this little thing where the arrow is. And so we'll never really know if we're in the right spot. Sorry. So again, when we have the information that we need, then we can see those critical landmarks. We can see the trochanters, the ischium, the obturator foramen, and the pelvis, all that good stuff that can help us establish that sup inf. So always use that. So here's a quick question. What are some adjustments you might make looking at this?
Hello.
Yes, hi.
Yeah, you might want to make adjustment with having in mind that you must still allow lymphatic flow to go uninterrupted to avoid the formation of lymphedema. That's in this plan, there must be a strip of skin that is still allowed that the treatment will not cover, such that there can still be lymphatic flow, especially when it has to do with the limbs and with the extremities. To avoid lymphedema, lymphatic flow must be very properly taken care of. The lymph must still flow.
Yes, very good. That's correct. That's good. So looking at this, we're going to match and watch the therapist. They're going to kind of go left to right. They're starting with the upper area, the greater trochanter here. And they're doing that because you could see that the patient is crooked here. And so if we match the bottom of the leg to fix this, we're going to have to move the patient from the hips. This can be done, but it's riskier because when you pull a patient at the hips, you're working with that femoral head, which is a ball and joint area. And so you can roll the leg, it can make the pelvis crooked, you can roll the pelvis. What's easier to do is to match to the top like this therapist did, and then look at the bottom. Now the bottom we can see is off to the patient's right a little bit. And so what we can do is we can simply lift the ankle, and hopefully they're not in a vac lock, which will make this easier, but lift the ankle and kind of move it gently over to the left and then refilm to address that. So in this example, we're going to apply a couch kick. So we're going to look at that box and you're going to see it move a little bit. And so let's just go ahead and do that. So there's the couch kick. And so what's going to happen now is that we apply the couch kick, we're actually going to be off on the top. We're not on anymore. And so after you do a couch kick, you want to look at the whole thing again and fix your left to right. Always fix your left to right. And then check it again. And then that's a good match there. Okay, so here are some tips for looking at extremities and setting up the pelvic region. If you want to analyze the match in a more advanced way, you can look for 3D misalignment using just an AP, for example. The obturator foramen is a good indicator. You could see with these red lines here that these holes will change in size when the hip is rotated. One will appear larger and one will appear smaller. And that's an indication that maybe the hip is twisted and needs a rotation or a roll. Another thing we can look at is, if you look at the green arrows, is the space between the edges of the sacrum, which is you can kind of make out here, and the inside of the pelvis wall here. So if one is wider than the other, that's an indication that the patient is rolled. If I'm looking at this, I can tell that on this right side here, the patient is rolled up a little bit more. And I can see that because this space here is smaller. And whichever way the patient is rolled up, the sacrum will kind of go in that direction. So that's what's telling me that the patient is rolled up on the right side slightly. And that might be normal because of the screws in here, et cetera. So, but that's something that you can use. Also, we can use the trochanters here to look at leg rotation. These also change in appearance as the leg is rolled. So these are good examples of how we can kind of look at imaging on a deeper level. And as you kind of continue, you'll begin to build relationships between all of these structures, the SI joint and all of these other structures here in the area. So extremities can be hit or miss. Sometimes they're quick and easy. Sometimes they're difficult to set up. Just remember to ask yourself if readjusting is the best choice. I'm a perfectionist, so I'll chase it. But sometimes we're giving, something's already good and we're trying to make it perfect. We can make it worse. So just always kind of use your best judgment and make sure that the setup is good. And try to avoid using the couch as much as possible, unless you need to. So here are some takeaway notes for extremity. And we can take a look at some of these. So marking the patient, when you're working with an extremity, what can be extremely helpful is marking the patient and CT, and even on the VSIM day, add marks to help guide you aligning the leg, the arm, whatever it is. It can save you a lot of time and a lot of headache. Sometimes when we are imaging a leg, for example, let's say, and we have a straight lateral, our image is going to show us both legs sort of overlapping each other. That can be a little difficult to delineate, to kind of see which leg is which. So a couple things we can do to help distinguish those two legs. Sorry, excuse me. Is to maybe do an on-demand image. So if we take a slight oblique, we can see one leg more clearly than the other, and then we can kind of make small adjustments from there. We can, in CT, elevate one leg maybe, or move it out of the way so that when we're imaging, we can see the other leg a little bit more clearly. And we can always ask dosimetry to put in some oblique setup fields. So when you're performing the sim or when you're doing the treatment, think about the imaging for the patient. So when you're offsetting the patient, when you're using immobilization devices, when you're trying to separate the extremities, et cetera, just think about the imaging, and chances are you'll have an easier time on treatment when you're treating that site. Another good piece of advice is to use the proper techniques and filters. If you're looking at soft tissue, make sure you're using a filter that highlights that, a technique for your imaging that highlights that, and so that you can perform your match a little bit better. And then finally, take your time with extremities. They can be very complex and time consuming. Try not to rush it and use your best judgment. What I usually do is I ask myself, I think about what I would want done if I was the one on the table. And that is usually a good guide for me when I'm setting up extremities and deciding, should I move or should I not move the patient, et cetera.